This conference will now be recorded.
All right, so chapter 26, trauma overview. Pass all these competencies here that we already know about. All right, so trauma. We don't see as much. We see more medical than we do trauma. However, trauma is still there, right? We still get a big majority of calls that involve some type of traumatic injury, whether it be a trip and fall or something that's completely bad, motor vehicle crashes, ejections, things like that. Excuse me. So we look at unintentional injury, right? So unintentional injury is the primary cause of death and disability in people ages 1 to 44 years old. So proper pre-hospital evaluation and care can minimize suffering, long-term disability, and death from trauma. Remember that we look for the golden hour that still exists in pre-hospital trauma life support, along with the Platinum 10, which was the first 10 minutes of patient contacts, right? So we look at the Platinum 10, getting the patient out into an ambulance and starting that transport to a trauma center. So evaluation of mechanism of injury for the trauma patient will provide you with an index of suspicion for different types of serious and or life-threatening underlying injuries. We look at if someone crashes a car, we see this pattern, we expect these injuries, whether they're actually going to be there or not. It's still that suspicion, index of suspicion that we think might actually be happening. So we'll get more into that here in a second. So energy and trauma, right? So traumatic injuries occur when the body's tissues are exposed to energy levels beyond their tolerance. So if we have a motor vehicle crash, how many impacts are there?
Three.
Three. What are they? There are three impacts with the motor vehicle accident with when it comes to traumatic injury.
Motor vehicle to object, person into motor vehicle, organs into skeletal system.
Perfect. Exactly. Those are the three impacts that happen. So we got to expect injury patterns. Think like an ALS provider with the anatomy and physiology that we know and the pathophysiology behind it, right? So if you have a patient who's in a motor vehicle accident, okay, not wearing a seatbelt, and the steering wheel is bent, what do we think right off the bat for injury? What do we think?
Severe chest trauma.
Go more in depth than just chest trauma. Keep going with it.
Organs.
Aortic dissection.
All right, aortic dissection being one. So aortic tear, Justin just said. What else? Matt, you said something too. What was it? I think it was Matt. Actually, it has Matt.
I said organ damage.
Oh, Kenny, organ damage. Sorry. So organ damage. Keep going with us. So injury patterns. What are we seeing? Lungs, right? So not just punctured lung. What's the technical term for it? What's the name? Collapsed lung.
Neurothorax.
Pneumothorax. Yeah, pneumothorax. Okay. What about the heart?
Coming to
Was it tamponade?
Tamponade, yeah. Cardiac tamponade, pericardial tamponade. So how can we tell pericardial tamponade?
Muffled heart sounds, narrowing pulse points, and
Tell your kid to say JVD.
Kuzma respirations.
Right? JVD being the third, otherwise known as Beck's triad. Can we fix that in the field?
No.
No.
Maybe Life Flight, DART. The Vermont team can do it. The medics for their flight crew. Pericardial centesis, pulling the fluid out. So we got to start thinking like that. If we have a motor vehicle accident, what, not just chest trauma, but go beyond that. Pneumothorax, tamponade, right? Aortic dissection. We got to start thinking more towards those terms, right? Vehicle into a tree with starring on the windshield, right? We start thinking about head trauma, head facial trauma, right? Cervical spine. So look down the pattern, the index of suspicion, and that pattern of where we will see these bodily injuries, okay? And start planning for that, looking for signs and symptoms of what could potentially be wrong. Okay, we talked about another one with head trauma, okay? I know we're kind of going, well, this is trauma anyways, but let's talk about head trauma for a second, right? How do you know if a patient has intracranial pressure increase based on traumatic event?
Fluid leaking from the ears.
Okay, so we have cerebral spinal fluid, CSF, right? We can do the halo check to maybe see what that's actually that. But someone who has other increase intracranial pressure, what are 3 things we can look for and what triad?
Uneven pupils.
Well, that would be also correct. Not part of the 3 things to look for, though.
Beck's triad?
Beck's is pericardial tamponade. What else?
Cushing's triad?
Cushing's, yeah. What is Cushing's? What would Cushing's triad be? Who's using Google right now to look it up? Someone give me the 3 things for Cushing's triad. I'll give you 1. Irregular respirations.
Widened pulse pressure?
Yeah, so hypertension, right? Give me a 3rd one.
Bradycardia.
Bradycardia, yep. So if you see that hypertension, bradycardia, and irregular respirations, right, we're looking at Cushing's triad, which would be increased intracranial pressure, right? And I've seen that in the field quite a few times with patients with head trauma myself. So again, it does exist, it's there, and you gotta be able to pick up on it. So how can we tell if a patient's getting too much or too little? Let me rephrase that question. What is one thing we can do to help measure some of that to make sure they're getting the correct ventilation?
Capnography.
Yep, exactly, capnography. So patients with head trauma should be on end-tidal CO2 capnography to meet what range? What's our range the patient has to be at?
35 to 45.
Perfect. And how do we fix that if it's too high or too low? How do we fix that if it's too high or too low?
It's really going to depend on the or the ventilation, right? Or how hard you bag them, or how hard and how quick and fast you bag them.
It's 100% correct, London. Yep. 100% correct. We can manage intracranial pressure in the field to our best abilities by ventilating appropriately based on end tidal. Looking at the end tidal CO2 readings. Okay. Too much carbon dioxide or too little carbon dioxide in the system can cause vasoconstriction and vasodilation. And the last thing we want is to constrict or dilate the brain. We want to keep it normal. And to fix that, we have to be able to ventilate. To ventilate, to measure perfusion, we have to put on end tidal. Okay? That's why it's so important with trauma patients, we run end tidal CO2 on these. All right. Let's move forward. So different forms of energy produce different kinds of trauma. Mechanical energy is energy from motion. Okay. Kinetic energy reflects the relationship between the mass, the weight of an object, and the velocity or speed at which it is traveling. Potential energy is energy stored in an object, such as a brick sitting on a building. There's potential energy, and once that falls, Now we have weight and motion and speed, right? Chemical energy is energy released as a result of a chemical reaction. Thermal energy would be energy transferred from sources that are hotter than the body. Barometric energy or results from a sudden or radical change in pressure. Okay. And kinetics is the relationship among speed, mass, and direction of force. Where would we find barometric energy? Where would you find barometric energy?
Mountain climbers?
It changes, right? You may have barometric trauma on patients that are diving, right? Yes, mountain climbers going up extreme heights also have changes in pressures, but divers have it worse, right? What happens if a diver goes down, let's say they're down for, let's say, 30 minutes, and they're down 100 feet, 200 feet, and they come up really fast?
They'll get the bends if they don't blow out their lungs.
If they don't blow out their lungs, they'll have the bends, right? And what do these patients need to correct this?
Hyperbaric chamber.
Yeah, hyperbaric chamber. And where is there a hyperbaric chamber?
One that's capable of handling that kind of procedure is the nearest one, I think, is at Portsmouth, isn't it?
The last time I checked into this, it's been a little while. Nowhere near me. No. Was Boston. So again, we have to be able to pick up on these things as well. So I know Boston has them. They're the ones closest to the Manchester area. I don't know if any. I'm not sure if Portland has one enough for diving or not.
Melrose Wakefield has one.
Yeah.
I know Coast Guard facility in Portsmouth, I believe, Portsmouth has one.
Okay.
I know there's at least one down in Rhode Island. There's one in the Cape. And I want to say that I think Salem Hospital even has one too, but I'm not 100% sure on that.
Now, a lot of hospitals have hyperbaric chambers, right? But they're used for wound care. You got to find one that's meant for diving.
Yeah, I was getting ready to say that we take a couple people to the VAs when we had that contract, and it was literally for wound care. They had a bunch of them, but they said that if you have anybody that needs anything other than wound care, you got to take them to a trauma facility.
All right. So what else would require a hyperbaric chamber? Since we're on that topic really quick.
Carbon monoxide poisoning also requires a hyperbaric chamber.
Absolutely. For the patients that have high carbon monoxide levels in their system that we can't flush out with oxygen, will require hyperbaric chamber treatment. Awesome. We're all on the right track. We're thinking. So mechanism of injury profiles. Some different types of MOIs will produce many different types of injuries, which we already talked about. Injuries sustained by trauma patients that may be the result of multi-system trauma, falls from heights, motor vehicles, and motorcycle crashes, vehicle versus pedestrian, gunshot wounds, and stabbings. Maintain a high index of suspicion for serious unseen injuries. Injury patterns are going to be different for a child than they are going to be for an adult when it's versus a pedestrian, right? So what are the differences between, other than height and size? What do kids do when a vehicle comes at them?
Faces it.
They turn towards it because they don't know the difference, right? What do adults do?
Turn away.
Or jump.
Turn away, try to move or jump. Where a kid will duck. Exactly. Where a kid will just stand, turn, and stare until they get hit. Okay. So injury patterns may be different from side to front to back. With little kids, like infants walking around, or pediatrics, are probably going to be down and under versus adults that might go up and over depending on the size of the vehicle. So you're going to have to start thinking about different patterns of injury, not just walk up and say, oh my God, someone got hit by a car, you got to treat them. Wait, what are we treating? What's the most important thing to do? That's what we have to look at as ALS providers, is correct the life-threatening injuries first. Just because they have an open tib-fib fracture that's not bleeding does not make that a priority. If they're not breathing, if they have internal bleeding, if they have a femur fracture, if they have a pelvic fracture, those are critical injuries that can cause a patient to lose a lot of blood, even for those unseen injuries as well. Right? We can't see a pelvic fracture most of the time. Right? So those are ones we got to palpate, touch, and look, listen, feel, those kind of things to find out if they actually truly have one, then stabilize it right away. Right? So look for those index of suspicion for the unseen injury. Blunt trauma causes injury without anything penetrating the soft tissues or internal organs or cavities. So again, motor vehicle accidents, falls, those are blunt force trauma, getting hit by a baseball bat, whatever. Penetrating trauma or injury by objects that pierce and penetrate the surface of the body and injure the underlying soft tissues, internal organs, or body cavities, stabbings, shootings, impalements, things like that. And we're going to be covering all these in detail on the chapters coming forward in the trauma section. So a lot of this stuff here is just a quick overview. Results from an object for blunt force trauma, results from an object making contact with the body. Right, I'm going to have some pictures in the next couple of slides here for you to take a look at. All right, I want you to tell me what you think you would find for injury patterns. Motor vehicle crashes and falls are two of the most common mechanisms of injuries for blunt force trauma. So we're going to maintain a high index of suspicion during patient assessment for those hidden injuries. This is why we have to make patients trauma naked. This is why people have been questioning me lately about, why do I keep a gown on the stretcher? Well, this is why. Because we're going to get them trauma naked, assess the patient, and put a gown over them to protect them and keep them a little bit warmer and obviously making the more decent for them. Right? We have to look.
Hey, Kevin,
Yeah.
that was last night, and that's because that paramedic happens to be a freaking moron.
That did not come out of my mouth, by the way.
It didn't have to.
All right. I think I surprised Matt last night too by putting that on there. Then I explained on why, and he goes, "Oh, well, that makes more sense." So this is why we do things, to make things better for the patient, easier for us. Expose, expose, expose. Professional exposing, by the way, keep that in mind. All right, so let's go to the pictures here. There are 3 collisions in a typical impact, which we already talked about. A vehicle against another vehicle, a tree or something, the passenger against the interior of the vehicle, and the third one would be the organs hitting body, right? So if you look at the pictures here, where would you suspect injury pattern? If you can see the photos. Let's say the blue car on the left. Injury patterns for that one. Just walking up. We haven't done an assessment yet. What do we think?
That's going to be more to the lower half of the body,
Okay. Why would you say that?
based on how the vehicles hit the object, and there's not necessarily, at least looking at this, any spidering on the window, that the
Good.
impact's going to be to the knees and the pelvis, and then up through like the lower spine and upward.
Perfect. So let's just say they had it down and under, like you're talking about, right? What injury patterns would you expect to find on the patient itself for a down and under? All right, so you have Justin, ankle, fib fracture, knees against dashboard. Most likely that's what's going to happen, right? Knees against the dashboard. What are we going to find with injury patterns there?
Femur into pelvic.
Right. So like Justin said here too, knees, femur into pelvis. So if we have a down and under, okay, we need to think about pelvic fracture, okay? Femoral head dislocation, where the energy is going to transfer and then stop, right? So that's what we got to think about. Perfect. Here's the third here, internal organs hitting. So as you can see, frontal lobe of the brain causing that significant impact, right? Things to remember also is going through and looking at when you have, we'll talk more about this about head trauma though, and like parts of the brain. But looking at this guy here in this picture, they're talking about internal organs against a solid structure of the body, right? Sorry. So severe deformity of the vehicle or intrusion into the vehicle correlates with significant mechanism of injury. The way cars are designed today, if you have intrusion to the inside of the vehicle, I'm not talking about the outside, they're designed to crumple. Right? Our vehicles nowadays are a lot safer. We go to motor vehicle accidents and say that person should be dead. They're not walking around on their cell phone. Right? If we have intrusion to the inside, we need to suspect significant MOI. This guy here in the picture on the right-hand side has injuries to the front and back of the brain. So up here, and you can see the bruising in the back as well. What kind of injury is that called? I ask you because this is all basic level knowledge.
Is it coup contra coup?
It is. Coup contra coup injury. That means that's when your brain is bouncing back and forth, back and forth. A way to kind of picture this actually happening is taking a walnut, putting it inside of a water bottle, and shaking it back and forth. And watch what that walnut does. That's a great example of what a coup contra coup injury would be. Yeah, spray paint can. And that's our brain bouncing back and forth, causing multiple contusions to front and back. Right? Perfect. So understanding mechanism of injury after a frontal crash involves evaluation of the supplemental restraint system. Were they or were they not wearing a seatbelt? In this picture here, was this person wearing a seatbelt?
Yes.
Right, and you can tell by the seatbelt marks going across. Determine whether the patient was restrained by a full, properly applied 3-point restraint. If the airbag did not inflate during the during the accident, it may deploy during extrication. So remember airbag drain times. Okay, and still always treat a bag live if it hasn't been deployed. Even if it has, they have secondary devices in some. Seatbelts may also cause unseen abdominal injuries, particularly in pediatric patients. So look for abrasions and or traction type injuries of the face, lower part of the neck, and the head. The chest. Does everybody wear their seatbelts appropriately? Let me rephrase that question. How is the seatbelt supposed to be worn?
Across the pelvis.
And then over the chest, right?
Yes.
Okay. Does everybody wear their seatbelt across their pelvis?
No, because it slides
No.
up.
Especially people that are overweight, right? People that are heavier tend to put their seatbelt over their abdomen across their belly button, right? Going over across that way. And that can cause significant internal damage. So if you are overweight, lift your stomach up out of the way, put your seatbelt on, tight against your pelvis, and then go from there. A lot of people don't do that. They get in a motor vehicle accident. Now we have more internal organ injury. So contact points are often obvious from a simple, quick evaluation of the interior of the vehicle. Supplemental restraint systems can also cause harm, whether they are used properly or improperly.
I found this on the web.
Really? Okay. Ejection, I don't know if my watch keeps doing that. Ejection results in a second impact injuries when the body comes in contact with the ground or objects outside of the vehicle. Like we have an ejection or whatever it may be. Looking at the photos here, right? So if you look at the arrows, we can see need a dashboard. We talked about this before here, transferring that energy to the pelvis, right? The guy smacking his head off a windshield here, right? Or this was somebody who's restrained. If they're restrained and everything is working appropriately in their vehicle, the pretensioners in the seatbelt should have activated, pulling him back against the seat, protecting his chest from the steering wheel and the airbag is going off. If you're not wearing a seatbelt, as you can see in picture number 3, or the one all the way to the right, you'll notice that we have energy being transferred to the pelvis, energy being transferred through the chest, causing a change in pressure, right, in the lungs. Remember, our lungs run on a negative pressure system, so we're changing the pressure gradient in the lungs, therefore causing potential for more injury. We'll talk about that here in a second. We have pressure going toward the steering wheel at the neck, and we also have the head smacking up against the windshield as well, causing facial injuries. So when I look at this photo all the way to the right, I'm suspecting these types of injury patterns right now. I'm thinking a frontal lobe injury, okay, with a coupe contra coupe injury as well, by smacking his face. I got orbital, maxilla, zygomatic bone. Those are all injuries to that side of the face. Cervical spine injury. I got the chest, so potential for a tamponade with pressure changes and bruising, right? I also am thinking of potential to have a pneumothorax as well, along with a pelvic fracture. I'm not thinking anything abdominal at this point in time at a front end impact because it's going down. There's not as much there. Those are the injury patterns that I'm looking for in this motor vehicle accident if he didn't get ejected from the vehicle. So we got to look at all these things when we take the patient out, and that's why it's so important to grab and look at the vehicle. Have someone look at the vehicle, even if the patient's ejected, look inside for other potential patterns of injury. There's nothing wrong with taking pictures of the scene and bringing them with you on your phone. All right? Show the physicians. They're the ones that need to start treating these patients. They look at mechanism of injury and suspicion index as well. Not only that, you can take those same photos and you can upload those to your run reports now as documentation. Right? So there's so many different options that you can utilize with these traumatic injuries and using your phone for pictures. All right? But we also need to look at contact points. So impact of the steering wheel can injure the lungs by generating pressure, right? Barotrauma. So the ring of the chest injuries that can occur from impact with the steering wheel or the dashboard, right? So we just talked about this in the last slide, okay? So you can look here, lungs can pop, alveoli can pop. You can have a displaced diaphragm, right? Because think about this here, okay? Our glottic opening is closed, therefore air is being trapped inside. As air is being trapped inside, I'm touching this so you guys can see it, right? Glottic opening being closed glottis. Air being trapped, lungs are inflated. Diaphragm being pushed down. Now we have impact to the steering wheel. Something's got to give. We're putting more pressure than there has to be into those lungs. They got to pop somewhere. Oh. So lungs pop. Diaphragm, right, becomes displaced. And then you can look here, all the different organs inside, okay? So bulging muscle, there it is. The bulging muscle in the supraclavicular area. Pleural space is now filled with air. Here's our wound site down here, our collapsed lung. Lung starts to shrink. Bulging intercostal muscles here as well, causing significant pain, unable to breathe, right? Decrease in saturations. These patients here need a paramedic right away. They need a needle decompression. Now, can this lung fill up with blood? What do you guys think?
Yes.
Yes. And what is that called? Good. Justin's got it right on the text. Hemothorax. It is great having a split screen so I can actually see you guys texting now. All right. So rear end crashes, right? They cause whiplash type injuries. What type of injury in the brain will we see with this potentially? We just talked about it. Yep. And it was Sean, I believe, that mentioned it too. The coupe contra coupe injury. So cervical spine and the surrounding area may also be injured as well. Are we using backboards to get patients out of vehicles still? No. But can they be used as an extrication device?
Yes.
Absolutely. Just get them off the board once we get them out. All right. So cervical spine, collars are still required. Okay. Still put a cervical collar on. And if it doesn't fit, then we got to make one out of towel roll or something like that. If they're like a no neck and our collars don't fit the patient, their necks are too big, or a shoulder, they have a no neck patient. We got to make modifications. We still have to find a way to stabilize. Right. Patients may sustain an acceleration injury to the brain, coupe contra coupe injuries. Passengers in the back seat only wearing a lap belt may have a higher incidence of injuries to the thoracic and lumbar spine. If we have a lateral crash, like whiplash injuries. The patient could experience rotation of the neck, lateral flexation, or a combination of both, right? If there is substantial intrusion into the passenger compartment, we want to make sure that we think about suspecting a lateral chest or abdominal injury on the side of the impact, as well as possible fractures to the lower extremities, pelvis, and ribs. Okay, so that lateral, that side impact as well. Rollover crashes, well, they're rollovers, right? So injury patterns are very difficult to predict. Are they belted, non-belted? They can be thrown around in a vehicle. Or as you can see in the picture here, partial ejection. An unrestrained passenger may have sustained multiple strikes within the interior of the vehicle. So it's kind of hard. If it's a rollover, suspect everything's broken. So we have no idea until we start ruling things out and start doing an assessment. So the most common life-threatening event in a rollover is ejection or partial ejection of a passenger, as you can see in the photo here. So injuries are the result of a combination of frontal and lateral impacts as it's rolling over, rotate like a rotational. I should say roll over, rotational spin. So the 3-point seatbelts are effective in preventing injury in angled crashes up to 45 degrees. Okay, we start getting rollovers, then things can definitely change. But rotational crashes are this. Vehicle versus pedestrian crashes. So there are 3 phases of impact: vehicle, pedestrian impact. Pedestrian rotates onto the hood, and the pedestrian rolls off the hood onto the ground. Or if it's a pediatric, down and under and run over. The injury patterns may depend on the height of the pedestrian and the body area facing the impact. Remember, we mentioned kids turn towards, adults turn away. Multi-system trauma is very common after these types of incidents, so we need to make sure we're doing a full hands-on assessment. And once again, they need to become trauma naked. We have to assess everything. Evaluate the MOI is in much the same manner as you would with a vehicle versus pedestrian crash. Evaluate the damage to the position of the bicycle, if it's a bicycle crash, and presume that the patient has sustained an injury to the spinal column or spinal cord until proven otherwise at the hospital. These patients do not get up, they do not walk, we do not make them walk to the stretcher. These patients are boarded, picked up, put onto the stretcher, unboarded. That's why we use scoop stretchers now, because they're a lot easier to utilize. Scoop them up, put them on the stretcher, they come off of it, we transport. As far as motorcycle crashes go, as you can see, this guy has quite the abrasion, road rash. So patients should undergo a cervical spine assessment and have cervical collars placed if indicated. Okay. Again, if they're involved in a significant crash, right? Don't take the time to rule it out. Just put a collar on them and move forward. Still do a neuro assessment. Look for the deformity of the motorcycle itself. Again, take pictures. The side of the most damage, the distance of the skid in the road, the deformity of the stationary objects or other vehicles that it hit, and the extent and location of deformity in the helmet. Bring the helmet with you to the hospital so the physicians can see it, right? Especially if you go to a trauma center, they're going to ask, do you have the helmet? Right, so make sure you bring it with you. There are 4 types of motorcycle impacts: head-on, angular, ejection, and lying the bike down, also known as a controlled crash. Bicycles and off-road vehicles are capable of producing injuries similar to those of a motorcycle with a few differences. The biggest difference reaching the patient is often a challenge. And patients are often not wearing helmets or other safety equipment like they would be on a motorcycle. All right, falls. So the greater the height of the fall, the greater the potential for an injury. What do we use as a rule of thumb to consider it being a significant injury of a fall for height?
Is it 6 feet?
Usually 2 times the height of the patient. We consider it a significant fall. But you could fall 4 feet though, right? And still be injured. Right? Then we started looking at medical history and things like that into it as well. You know, grandma falls down from a standing height can actually legit fracture their hip. That could be a significant injury. Right. So the rule of thumb usually for the pre-hospital trauma life support stuff is usually 2 times the height of the fall is considered a significant fall. But we got to take into factors into account of height, the type of surface that was struck. Was it grass, concrete, pavement, water? The part of the body that hits first, which allowed the path of energy displacement. So if you land on your calcaneus, as you can see in the photo here, we expect displacement of energy to move up toward the pelvis. What about a diving injury? What about diving injuries? Where would you suspect those patterns?
Downward to like head, neck, back, lower back.
Yep. So if you talk about spinal injuries, right? Would you expect hyperflexion and hyperextension?
Yes.
Yeah, absolutely. So what about surfing? What type of injuries can happen with surfing?
Shark attack.
Shark attack, love it. But if they're on a surf, right, and they go down, they lose the board, they go down into water. What's happening within that wave? What about the hydraulics of the wave? What is it doing to the patient?
All the compressions and the internal organs getting thrown about.
With the inability to control, right? They really can't control their swim. So if they hit the ground with their head, is it necessarily just a hyperflexion or hyperextension, or would it be rotational as well?
Rotational.
Yeah, absolutely. So start thinking about those different patterns that you're going to come in contact with, right? Surfing incidents have a higher index of suspicion, right? Versus somebody's regular diving incident just dives in because there's more going on with the hydraulics of the ocean and the waves. Something to think about, that's all. So the area of the body in which the impact is distributed, look at that there. So injuries from many falls, especially those sustained by older people, are not the result of a high energy trauma. But an older patient with osteoporosis can sustain a fracture as a result of a fall from standing positions. So always consider syncope or other underlying medical causes of the fall. Why did they fall to the ground? If it's a syncope, now we're dealing with a medical and a trauma, right? 12 leads, IVs, things like that, to try to determine why they passed out. Orthostatic blood pressures. Unless they have a pelvic injury, then obviously we can't get orthostatics. All right, penetrating trauma can be classified as low energy, medium energy, or high energy. Low energy penetrating trauma may be caused by accidental cause, by impalement, or unintentionally by a knife, ice pick, or other types of weapons. And we'll go over more in depth on this stuff later in the program. Right, point blank, high velocity gunshot wounds result in more significant injuries. The body area that is involved also can be estimated by looking at the location and entrance and the length of the weapon, if you have it, or the angle or direction of travel is also pertinent. So in gunshot wounds, the internal organs that are injured may have no relationship to the entrance wound or the exit wound. Remember, because bullets can bounce off bones. It ricochets and moves, right? So if you have a GSW to the chest, it could bounce, let's say the right side of the chest, it could actually bounce and ricochet down towards your abdominal cavity, or go to your spine, or move up towards your heart, or again. So don't just play it like it's okay. Well, it's here. Look for the exit wound as well. If there's no exit wound, then where did that bullet lie inside? First, determine the number of penetrating injuries that there are. So you have to expose your patient to see it. Combine that with the information that you know about the potential pathway. Look for that exit wound if there is one. Gunshot wounds as well. The path of the projectile takes is referred to as a trajectory, or where it's going. So frangible bullets will also increase damage as multiple fragments increase likelihood of multiple organ vessel sustaining injuries. Hollow point bullets expand as they enter the target in order to decrease penetration and cause more tissue damage. Full metal jacket bullets cause less damage than fragmented rounds, right? So this is things to think about. The bullet speed is a major factor in resulting injury pattern. I am not the person to talk to about bullets and guns. I know that it goes in, and hopefully it comes back out, and we can start treating what's in front of us. So I am not a gun guy by any means. If there is anybody in the class that wants to discuss it in further, they can. When we start talking about penetrating traumas later on in the program. Cavitation results from the rapid changes in tissue and fluid pressure that occur with the passage of the projectile. So, like, for example, like a temporary cavity is produced by stretching tissue surrounding the point of impact. As you can see, looking at the point of impact here in the picture, you can see the temporary cavity as it stretches out. Permanent cavitation injury results closer to the bullet path, where the pressure fluctuates or fluctuations are greatest, and remains after the projectile has passed through the tissue. All right, let me talk about these kind of hand wounds as well. So relationship between the distance and the severity of injuries varies depending on the type of weapon that was involved. Air resistance, often referred to as drag, slows the projectile, decreasing the depth of penetration and energy of the projectile, and then reduces the tissue damage. Exit wounds are often much larger than the entrance wounds, and police at the scene may be a useful source of information regarding the caliber and type of weapon. Right, that's the information the hospital is going to need as well. So get that information. Like I said, I'm not a gun guy, so I'm going to refer to other people on scene, like law enforcement, tell me what kind of gun it is and the caliber of weapon and bullets and everything else that are there, because that is not something of my forte. I'm not great with that stuff at all. Never actually studied it. All right, so any questions so far? Doing good? Perfect. All good. All right, so blast injuries. These are always the fun ones. So although most commonly associated with military conflict, blast injuries are also seen in civilian practice in industrial settings, or the backwoods of New Hampshire and Maine, I guess. So categories of blast injuries. We have a primary blast injury, which is entirely due to the blast itself, or damage to the body caused by the pressure wave generates by the explosion. Flash burns are part of the primary injury pattern. All right, so we have to look for flash burns as well. Organs generally affected are the lungs, eardrums, and other compressible structures. So the proximity to the origin of the pressure wave is associated with high risk or injury or death, as you can see in this photo here. This photo here shows you the mechanism of a blast injury. Right, we're going to cover more of these in detail here in a second. Right, so we look at the secondary blast, which results from being struck by flying debris, which may cause blunt and penetrating injuries. The tertiary blast injuries, which occur when a person is hurled by the force of the explosion or blast wind against secondary rigid objects, and injuries will result both blunt and penetrating as well. Right, perfect. So some of the tissues that are at risk, excuse me. So organs that contain air are the most susceptible to barotrauma, right? So the lungs. What other organs do we have that are hollow? I'll give you some more hollow organs. Just give me one more. Hollow organs. I got stomach. Anybody else?
Liver?
Liver is going to be a solid organ. Kidneys are a solid organ.
Was
Right.
it
What about? That's okay. What about the intestines?
ovaries?
Okay. Gallbladder, ovaries, intestines, large intestines. They're all solid. I'm sorry, all hollow. I mean, right. So those are all susceptible and have air. So they're most susceptible to barotrauma because we can put pressure by squeezing, causing them to pop and rupture. Right. And what's inside of those hollow organs, especially the stomach?
Fluid.
Not just fluid,
Acids?
acids. Right. So our organs are meant to stay closed. So when something ruptures inside, those contents then spill out into the abdominal cavity. That's bad, right? Okay, so we want to make sure we recognize this and we feel. And as we're palpating the stomach, we're going to look for something called ascites, right? Ascites or rigid abdomen. I'm not talking about somebody that has rock solid abs. Right? I'm talking about true rigidity, right? So we start noticing that ascites are and also the drawing a blank, distension as well. So we look for that as part of our assessment, right? If stomach acid is getting in there, it's very necrotic, okay? It can cause significant infection. Right? These patients need abdominal surgery right away. So tympanic organs that contain most of the barotrauma, we have tympanic membranes, which can help determine the possibility of presence of other blast injuries. Where do we find a tympanic membrane? Ears. Yep. Good. So patients reporting ringing in the ears, pain in the ears, or some loss of hearing and blood may be visible in the ear canal. So you need to actually take a look. I'm not saying take a scope and look inside, but look for any presence of blood around the outside of the canal. Pulmonary blast injuries result in short-range exposure to the detonation of explosives. So the primary blast injury, often characterized by a lack of external visible injuries. So the patient may report tightness or pain in the chest and may start coughing up blood. Subcutaneous emphysema may be detected over the chest using palpation, indicating air in the thorax. What would that feel like, subcutaneous emphysema? What does that feel like when you palpate it?
Like Rice Krispies?
Yep. It's like Rice Krispies. Popping crackles. Good, good. Pneumothorax is a common injury that may require emergency decompression as well. Collapsed lung. Pulmonary edema may also occur rapidly as well. Arterial air embolisms. Solid organs are also relatively protected from shockwave injury, but may also injure in the secondary missiles or a hurled body. Hollow organs may be injured by similar mechanisms from a lung as for a lung tissue. Underwater explosions result in the most severe abdominal injuries for underwater. Neurological injuries and head trauma are the most common causes of death from a blast injury. All right, so multi-system trauma, we're getting close to the end here. Injuries of a person who has been subjected to multiple traumatic injuries involving more than one body system. So multiple system trauma is not multiple skeletal muscle injuries, right? It's body systems. So skin, respiratory, cardiac, GI, all the different systems the 11 body systems we have. If more than one body system is involved, now it's multi-system trauma. And a lot of people misinterpret this as, oh, they got a broken arm, broken leg, or broken pelvis. It's multi-system. No, it's not. That's just a lot of musculoskeletal injuries, right? So we have to look at that. Recognize patients who fit this classification. Provide rapid treatment and transport and alert medical control. Patients have high morbidity and mortality. Patients die from multi-system trauma. We have to recognize this in the field and start treating what we can. The way I like to look at advanced EMTs are pretty much trauma techs. You guys have the ability to deal with a lot of trauma minus pain management. But you guys have IV therapy, you have fluids, you have the ability for tourniquets, you have the ability for quick clot now. And I wouldn't be surprised if TXA will ever make it down to the advanced level at some point in time in the future. Right? So again, you guys are like trauma techs, and that's the way it should be. You guys, the knowledge you guys are getting through education plays a huge role in this. So the golden principles of pre-hospital trauma care are ensuring safety, determine the need for additional personnel or equipment, evaluating the mechanism of injury, and identifying and appropriately managing life threats. So we're going to assess and manage the airway while maintaining cervical spine immobilization. We're going to keep running through. We're not going to take a break because we probably have about like 15 minutes left. We're going to ensure that the basic shock therapy is completed. Right? What is basic shock therapy? What do you think I mean by that? I'm not talking about IV. Yeah, not talking about IV fluids.
The oxygen, keeping them warm, keeping them level so they don't pass out and everything.
Yep. So position of comfort to meet homeostasis, right?
Yes.
What's our target blood pressure for significant trauma? What do you think it is?
90?
90 systolic. Correct. So why don't we want to have a blood pressure of like 140, 150 systolic?
Lose blood faster if internal bleeding?
Yeah. Making Kool-Aid, right? Putting more fluids in. Okay. We want to make sure that we give boluses, not slow drips, boluses of fluid to maintain a blood pressure of 90 systolic, providing oxygen, right? Because why would we give a patient oxygen that's in trauma? That is multi-system trauma or significant traumatic injury and bleeding. Why do we give
perfusing?
What was that?
Keep them perfusing.
Okay. So what are we losing when we lose blood?
We're losing volume.
Hemoglobin.
Okay. Volume. And what else though? What else is important in that volume of blood?
Hemoglobin.
Hemoglobin, red blood cells, right? Red blood cells transport
Oxygen.
Oxygen. So if we're replacing it with fluid, we could have a different fluid discussion another day, talking about hypertonic saline. That's a different class, right? We're giving fluids, right? Justin put down making Kool-Aid, right? If we're giving so much fluid, replenish the blood that's lost to make up for that volume, and we're not providing whole blood and as well, we're losing our red blood cells. And if you lose red blood cells, they don't have the ability to transport oxygen, which is why it's so important to put patients on oxygen that have traumatic injury, especially internal bleeding or external, to be able to flood the system more. I'm not saying hyperoxygenate, but to oxygenate the patient better, because we're losing that red blood cell. And then to maintain a blood pressure of no more than 90 systolic, and watching that heart rate. Also looking at end tidal as well, but watching your heart rates. Okay. We want to keep the heart rate lower. Okay. Not bradycardic lower, but normal, right around 90 or so, 90, 80, not 160. So to kind of bring this into perspective about, Sean, I think you were on that call with me, weren't you? The ejection in Freedom?
The teenager that was ejected from the vehicle.
Yeah.
Yeah. Oh yeah. That's
Yeah,
fun.
that was we had 2 ejections in 48 hours, so I'm trying to remember which one it was. We get there and we found a 18-year-old, 20-year-old kid, whoever he was, on the ground, not complaining of any pain. I'm palpating his pelvis, right? No crepitus, nothing. Full body scan of this kid, rapid assessment, detailed assessment. No visible injuries. But the kid had a blood pressure which was, I want to say, around 100 systolic. So I put bilateral lines in place, but his heart rate was 160. Right? So I'm like, something's still not right. You get those spider senses tingling, right? Something's just not right with this kid. He's got an internal bleed. I just can't see it. I can't find it. There's a fracture somewhere. There's a bleed somewhere. I just have no idea where it is. So based on my clinical judgment, looking at my experiences that I've had in the past, taking all that stuff that we've learned through school, I said, this kid's got a bleed. Bilateral lines. We'll give him a little bit of fluid, and I'm going to give him TXA. Right? So I gave him a gram of TXA. Get to the hospital. Come to find out, the kid had a pelvic fracture with a bleed into his pelvis. But TXA saved that kid's life. Okay, but he had no pain. But the index of suspicion, the ejection, the rollover of the vehicle, the whole deal, that index of suspicion that I had, looking at vital signs and what I saw on scene, made me realize this kid had an internal bleed based upon the fact that his heart rate never changed after 1,000 of fluid total. There were no heart rate changes at all. This kid had an internal bleed. The thing is, he was still in compensated shock, and it was early stages. Recognized it, gave the kid TXA. That promoted the clotting it needed to promote. The kid went to surgery. He was transferred out to a trauma center, surgery, and from what I've been told, the kid's still alive. Based on index of suspicion, some things just didn't feel right with the kid. So again, they don't have to have all the signs and symptoms to make it something internal. And if it's a pelvic bleed, you're not going to see it. There's no bulging, nothing pops out. You're not going to see the types of bleeds. You got to base it based on vital signs. Vital signs and presentation. The kid was so pale too. He just, for some reason, he was maintaining very well. All right. So during the transport, we get a sample history. And for critical injured patients, consider paramedic intercept or air medical transport. Consider where your trauma centers are located. Justin, where's your closest trauma center to Island Falls?
117 miles south in Bangor.
Right, so Eastern Maine Med?
Yep.
Yep, 117 miles for your closest trauma center. Right? Those patients most likely are going to be flown from the scene, I'm guessing.
We usually drag them up to Holton and they stabilize and ship from there.
Right, but if you have the ability for flight,
Oh yeah.
Absolutely. Know your system that you work in. Identifying life threats and illnesses and injuries as soon as possible improves patient outcomes. I just gave you a story that happened within the last 2 months. I identified a life-threatening illness or injury. I stabilized him, gave him TXA, and it saved his life because of that. Assess, triage, treat, transport patients with traumatic injuries to the most appropriate facility. Right? I didn't feel comfortable taking this kid with his heart rate sustaining that way all the way to Portsmouth from where we were. That's a long ride. This kid needed to be brought to an ER, stabilized better, X-rays being done, and find that bleed, and start getting blood products if needed. Injuries to the head, as far as patient assessment goes, disability and unseen injuries to the brain may occur. Okay, so we need to make sure we're doing proper assessments, neuro assessments. Right, bleeding or swelling inside the skull from the brain injury is often life-threatening. Brain bleeds are bad. Look for signs and symptoms: headaches, blurry vision, numbness, stroke-like symptoms. Neurologic assessments, coupled with patient's level of consciousness, will often provide details and subtle changes in patient's condition. Right? End title: neuro assessments, checking cranial nerves. Right? Doing that in-depth assessment that I showed you guys before during practical evolutions we did. Injuries to the neck and throat. Injuries may result from airway problems. Looking for deformities or decap ETLS. Swelling also may prevent blood flow to the brain. Always use an occlusive dressing on any open neck wound. Same thing with chest as well. We want to make sure we don't let air in. Air in the circulation of an airway cartilage fracture may cause rapid death. Something we don't want to happen. Injuries to the chest. Remember, the blunt trauma can fracture ribs or the sternum. Right? Large vessels of the heart may also be torn as well, like aortic tears. Pneumothorax, or air that collects in the chest cavity, compressing the lung tissue, needs a needle decompression. Tension pneumothorax is when the heart becomes squeezed, right? Which then can lead into, if you have more buildup of fluid on the heart, pericardial tamponade. Hemothorax, or blood that collects in the chest cavity, which they're going to need a chest tube for. And reassess the trauma patient's chest region every 5 minutes. You want to listen to lung sounds every 5 minutes, right? And take a look and see what you got going on. If there's any kind of changes. Tracheal deviation in a patient with pneumothorax is a late sign. Pick up on it early. Absent or diminished lung sounds. Changes in pulse oximetry. Anxious, chest pain. Look for those different signs. Injuries to the abdomen. So the solid organs may tear, lacerate, or fracture. Solid organs are very vascular and can cause significant blood loss. Right? Hollow organs may rupture and leak toxic chemicals. Healthy young adults are able to compensate longer than others for blood loss. Like I just mentioned, I had the 18 or 20-year-old kid that maintained, other than his heart rate being fast. Right? Look past the fact that he might have been an SVT, because he wasn't. That was tachycardia secondary to trauma. Right? Maintain a high index of suspicion. That saved that kid's life. Reassess the abdominal region using decap ETLS as well. Palpate, inspect, auscultate, listen. Right? Make a transport decision. Looking at the trauma lethal triad here. Right? Hypothermia, coagulopathy, and acidosis are major contributing factors to death in patients with severe traumatic bleeding. Right? Factors that interfere with blood clotting may cause more blood loss. Aggressively seek and control all bleeding, and do not hesitate to use a tourniquet. Back in the day, they used to say, oh, tourniquet if last ditch effort. No, tourniquet patients now. Right? Stop that bleed. Right? Aggressively seek and control all bleeding, tourniquets if needed. Ensure IV fluids are warmed to at least normal body temperature. Please use fluids off the warmer. Hypothermia kills trauma patients. Right? Every ambulance you work on should have an IV warmer with ringers and saline, both in there. Unless you're in Massachusetts, remember, it's because ringers are not within the scope of practice even for paramedics. But for New Hampshire and Maine, you should have a bag of each, liter bag of each on your warmers and administer those to patients. Cold fluids are not good for patients, right? Unless they're like therapeutic hypothermia or patients that are hyperthermic to help them cool down. But even room temperature fluids are better than nothing. But for patients that are in trauma, warm, not cold, right? Minimize the volume of acidic IV fluids administered to prevent interfering with coagulation and contributing to acidosis. So monitor end-tidal carbon dioxide and ventilations and consider calling for paramedic backup. We can monitor forms of acidosis by using end-tidal, right? We can look at bleeding and coagulopathy by monitoring blood pressure and calling for paramedic care to give TXA, right? Hypothermic patients, we have the ability as AEMTs to start IVs and give warm fluids, right? Minimizing your high heat loss areas, sides of the neck, the groin, right? As well as the armpits. Heat packs work wonders, warm the patient up. If you don't have warm fluids on your ambulance, heat packs around the bag of fluid and put more heat packs by the site where the IV is as it warms fluids going in. Right? Scene time, platinum 10 minutes, 60 minutes to the time they get definitive care, golden hour, right? Limited on scene time. Criteria to identify critically injured patients. Dangerous MOI, decreased level of consciousness, any threats to the airway, breathing, or circulation, very young or very old, and chronic illnesses. There's two types of transports, right? One is ground or air, or ground in or air, so the two type. Several factors should be taken into consideration as well of which one you're going to utilize. To be familiar with your local protocols, define indications for use of air medical transport. So what I want you guys to do before we break, because we have plenty of time, I'm going to show you guys a video as well. I do this with my EMT classes. I'm going to do the same thing with my A class on air medical transport and what they can offer. The Association of Air Medical Services, Medevac Foundation, all this kind of stuff here. As far as destination goes, patients need medical care and stabilization at the advanced life support level. They do. AEMTs are considered ALS. Consider air medical transport for distances to trauma centers greater than 20 to 25 miles. Traffic conditions or hospital availability, air transport to mitigate the effect of delay caused by EMS systems, and MCIs as well. So you can utilize those different things. Again, look at your scene, look at the mechanism, look at the patient condition, and can you get a patient to a trauma center faster? Remember that helicopters can bring blood. Okay, that's a key thing behind that. So know the criteria for referral to a trauma center and what their hospital resources are available in your area. So again, with that being said, know your local protocol and your bypass protocols. There are different levels of hospital, level 1 to level 4. All right, and there's critical access. Your level 1 trauma centers have the only difference between a level 1 and a level 2, other than it being a teaching hospital, is having a neurosurgeon not on staff, but in the hospital 24 hours a day for neurosurgery. Portsmouth Hospital has 24-hour-a-day neurosurgery now. The only thing they do not have is the ability. They're not affiliated with a college yet. So I know they're working on that to become level 1. Maine Medical Center, level 1 trauma. Dartmouth Hitchcock, level 1 trauma. Right, and obviously the bigger Boston hospitals. All right, so let me bring up that video really quick that I wanted to show you guys. Hopefully it works. Let's see, and then we'll call it a night. I just got to open it up really quick. All right. If you guys want, you can take 5 minutes, come back while I bring it up. It's up to you, or you can just stay on. I'm just gonna show you like a 10-minute video, and then we're gonna be done for the night. Let's see. You guys still there?
Yep.
Awesome. Let's see if this will work. I'll stand by a second here. Excuse me. So I'll share a different screen here. All right, can you guys see my screen okay? Yes, okay. You see the YouTube video I'm putting up? Maybe. Okay. So a 10-minute video, and then we're gonna call it a night. Hopefully it starts loading.
DART is the only helicopter EMS within Vermont, New Hampshire. We provide a service like few others across the United States.
We have the equipment and the training to handle life support missions.
We take care of the most sick and most badly injured patients, and to be able to help those people on a daily basis is incredibly rewarding. Now I can
We're on our way, and the plan right now is to land at your facility for a head injury coming out of Surrey. We should be landing in about 10 minutes. If that changes, I will certainly let you know, okay?
As soon as we get the call, we move out to the helicopter and we like to be off the ground in under 5 minutes.
Once we get the mission activated and the vehicle leaves here, then our primary function turns into keeping track of that vehicle. All of the programs in the Northeast belong to Fleet Eyes, which is keeping track of where the aircraft are all the time to keep from running into each other.
DART provides critical care transport when time is going to make a difference in the outcome of the patient.
We bring the hospital to the patient and continue that level of care until they arrive at the receiving hospital.
I like to describe DART as an outstretched hand, extending the reach of DH and the quality care that is known for our organization.
The DART program really stresses safety. They have all the safety features on this aircraft. They have all the rules in place. And so that to me speaks to the desire for Dartmouth-Hitchcock to provide a safe environment, not only for the people that work for them, but also for the patients that we're moving around.
Yeah, Dar 1's about 5 minutes out for landing if you could just let security know.
It's a fantastic resource, and it gets us to the patient in the most appropriate, safe way.
DART was the brainchild of a number of individuals here at the hospital who saw the need to have a helicopter transport service based here at Dartmouth Hitchcock Medical Center to transport patients from the rural regions of both New Hampshire and Vermont.
My interest in the DART program came up the day it was born because I was in the military at the time, and I heard, hey, they're starting a helicopter program in the place that I wanted to retire.
It was in development for a couple of years before July 1st, 1994, which is the day that DART went into service.
And once it got going, it became quite obvious that every year you have more and more patients to move as more and more people become aware of the service.
Now we have transported just slightly over 24,000 patients by both helicopter and by ground ambulance.
The vast majority of our missions are to rural hospitals and back here. Clearly, the most fun are when you go up into the mountains and you have to find some little tiny space to land or put the skids down on the uneven rocks.
To be able to land somewhere pretty remote is pretty challenging and very exciting. People will first notice that it is quite small inside the aircraft. Everything that we have is within arm's reach, and so we can always pass equipment back and forth to each other. We have an array of equipment that makes it more like a flying intensive care unit. One of the new pieces of equipment that we carry is a portable iStat, which can get a complete readout on the patient's blood chemistry through a drop of blood that we process through this machine. The red bag we consider our kind of our primary bag. And one of the things in the top of our red bag here is a video laryngoscope that helps facilitate placing a breathing tube into a patient. We carry 3 units of O negative blood, and we transfuse blood to our critically injured patients. We have it, the patient needs blood, we can deliver it in the aircraft. It can be a life-saving intervention in the field. So really, there are benefits in working in an environment that is smaller like this. This is a good size for what we do, and it's, as you can see, it's pretty well equipped.
The aircraft are operated by Metro Aviation. So every time we take off, Metro headquarters in Shreveport is authorizing that flight, and they look at every single takeoff, and they monitor our progress throughout the flight, and they also handle all of the mechanical issues with the aircraft and all of the normal scheduled maintenance.
DART's ground team provides the same level of service that we do by air.
They often back me up. They will do the time-sensitive critical care transports that I can't get to.
There's no delineation between the level of care you would get from the helicopter or from the ground unit.
One of the things we are challenged with is the enormous differences in weather. We fly in all sorts of weather that can change throughout the day, let alone the week or the month.
We have implemented a number of safety features, not only to the staff in the helicopter, but then also the patients that they're caring for.
First, they switched the type of aircraft to the EC-135.
We have added a new base in Manchester, New Hampshire, with a second aircraft.
We also added night vision goggle capability, which greatly enhances our safety margin because we can now see the mountains looming out there in the darkness. And then we added terrain awareness, and it will set off an alarm if you get too close too fast. And then finally, traffic awareness, which looks for other aircraft around us. So some great safety advantages that expanded our ability to conduct missions in poorer weather.
We're the first in the nation GPS approaches into various hospitals and helipads and various navigation routes.
It's low-level IFR, instrument flight rules, hospital to hospital, so we don't necessarily have to have an approach from airport to airport, primarily in New Hampshire and Vermont.
We can go to all of our local hospitals and local landing zones to get patients where other times weather in the past may have precluded that.
DART will be just a moment on the ground here. Take off.
All right. I'm not sure what the quality was for you guys to see that, but you can see what they kind of carry in there as well. So they bring blood, they have pumps, vents, critical care procedures that they can also do as well, that normal paramedics cannot. So Life Flight of Maine is no different. Boston Med Flight's no different to DART. And then DART also expanded into UVM in Vermont as well. So they have their own helicopter service at a UVM Medical Center in Vermont now. They have one helicopter scene response, as well as doing interfacility transport, which is also kind of overseen by the DART program. So, any questions on that at all? Do you think that video is helpful? Did you guys learn something different about flight medicine? What can be offered? How was the quality of the video when I showed it through there? They're always hiring, Mike, all the time. All flight services are. All right, so it came through well. Yeah, so they're always hiring paramedics and nurses as well. And then obviously they're helicopter, they're pilots. They're usually most of them are all like retired military. But yes, they're always hiring though. All of them are. And just for future, anybody who's interested at all, Boston Children's Hospital is hiring EMTs to paramedics right now for their ground transport team. Looking for pretty even full time. So if anybody's interested, I know they're looking to hire. I'm not sure the process you have to go through, but great experience levels. Great experience to be able to work with pediatric teams. All right, so that's all I had for you guys tonight. No class on Sunday. Okay, so don't show up in Tamworth unless you're doing clinical ride time. Make sure you guys follow up with the emails I sent you. I need to get that information from you guys as soon as possible so you can start your clinical rotations. Huggins, like I mentioned before, I will have that info for you. Kenny and Justin, I will reach out to Chris Azevedo again on Monday and become that pain in the butt to see if I can get that information so we can start doing our ride time in Maine. So hopefully that'll be more beneficial. I'd have to look it up. It's on my daughter has my phone, so it kept her out of the room while I was teaching.
Okay, the one I have for him ends in 1950, and I know that he said was direct to him.
If you want to just shoot that to me in a text, that'd be awesome.
Perfect.
That way there I can make the call, and I'll do it on Monday. Make sure I'll have the weekend off. All right, if there's no other questions, we're definitely done early tonight. So take that as an advantage. It doesn't usually happen very often. All right, be safe. I'll stay on the line if anybody wants to talk after. Have a good night. Kenny, yes, there is a quiz. I think you're already off, but yes.
Kevin, are we doing the quiz for, was it 2020 or 22, 23 or whatever, even though we haven't done the stuff in class yet?
No. I didn't even put that on the exam.
I saw it wasn't on the exam, but you reopened the quiz.
What did I do? Hold on.
So I just didn't know if you wanted us to take the quiz or not.